My talk today is on new approaches to TK2 deficiency. I, like Carlos, appreciated Carlos' introduction, and this is a disease-specific approach to one mitochondrial disease, TK2 deficiency. These are my financial disclosures. I am the holder of a patent that's licensed to Modus Therapeutics, which is currently called Zogenix, and that's relevant to some of the talk today, but I will try to present it in an unbiased fashion. So one group of mitochondrial disorders is due to defects, primary defects in the nuclear DNA that cause instability of mitochondrial DNA, leading to the accumulation of multiple deletions and depletion, or both, in affected tissues. And there are at least 26 nuclear genes that cause mitochondrial DNA maintenance disorders, and the one I'm focusing on is TK2, thymidine kinase 2 deficiency. These genes fall into three major groups: genes involved with mitochondrial DNA replication, or the replication machinery itself, the genes that are required for making the building blocks, dNTPs, that are required to make mitochondrial DNA, and a third group of disorders which are related to mitochondrial dynamics. So TK2, as I noted, is encoded in nuclear DNA, but the protein is imported into mitochondria, where it phosphorylates not just thymidine, but also the nucleoside cytidine, and that they make the monophosphates, which in turn make the triphosphate building blocks for mitochondrial DNA replication. So this is a story that begins with patients and identification of the genetic defect, and understanding the molecular pathogenesis, and developing preclinical therapy in the laboratory, which we've started to take back to patients. Actually, there'll be two parts to this story. So the introductory part about the disease was first described by Ansada in Israel in young children with early onset myopathy with early respiratory muscle involvement, and they had elevated CK due to the muscle damage and elevated lactate due to mitochondrial dysfunction, and the disease progressed rapidly with a mean age of death at about 2.5 years. And they identified the causative mutations in thymidine kinase 2 and proved that there was a deficiency of the TK2 activity that led to the mitochondrial DNA depletion. Subsequently, many other groups identified patients, and this is a review put together by Katerina Garon a couple of years ago, in which she summarized the literature and identified quite a few additional new patients, so a total of 92 patients with TK2 deficiency, and about 40% or so had infantile onset disease, another 40% had childhood onset disease, and another approximately 20% had late onset, adolescent or adult onset disease. So there's a spectrum of TK2 deficiency from very severe early onset disease to even a more indolent adult onset disease. And you can see that not only does the onset vary, but also the progression. So you'll see that the infantile onset patients have a much more rapid demise. Fortunately, their median survival, if their onset is in the first year of life, is approximately 1 year. Whereas those with the later onset have more slowly progressive myopathy and more prolonged survival. So you can see that there's differences not only well in the onset and progression of the disease, but also in the early onset disease. We're more likely to see CNS involvement with seizures in approximately 40% of those with onset before age 12, and some cognitive issues in some patients as well. But nevertheless, whatever the form it is, this is a progressive disease that's relentless, and there's no spontaneous remission of this disease, unfortunately. So we, with the support of a family, generated a knockin mouse model to study this disorder in greater detail. And the mouse replicated the infantile onset disease with very early onset. The mice stopped gaining weight about age 10 to 12 days and started to lose weight, and they had early demise in the 2nd to 3rd week of life. And they had impaired motor skills and a coarse tremor as well. And we noted that these mice, of course, had severe deficiency in the recessive form. So when they're homozygous mutant, they had severe deficiency of TK2 activity in all tissues that led to imbalances of the DNTP pools in mitochondria, and it varied from tissue to tissue. So in brain, it was predominantly a TTP deficiency, whereas in liver, we saw both TTP and CTP were deficient. And that in turn, of course, led to the mitochondrial DNA depletion. In contrast to the human disease, which is predominantly a myopathy, the mouse revealed more of a CNS disorder with brain and spinal cord involvement with severe depletion, and symptomatically a lot of their problems phenotypically were due to CNS pathology. So based on some work on cell culture with an analogous disease, DGK deficiency, that showed that monophosphates could be given to bypass the defect. Katerina Garon, when she was in New York, started using the DCMP and TMP monophosphates to bypass the biochemical defect in the mouse. And you can see here that with low and higher doses of the monophosphates, we can improve the growth of the mice. Not as good as the wild type, but certainly better than the mutants. And you can see that the mutant mice that are treated move better. You can see here it's untreated mouse. You can see his coarse tremor. There's the other one when he's stimulated, starts moving better. And of course, with that motor improvements, you can see survival improving 2 to 3-fold in a dose-dependent fashion. So that was very encouraging for us. Okay. We observed that when we were giving the monophosphates, we were actually not detecting it significantly in plasma of the animals, and we noted that it was being rapidly degraded to the nucleosides. And also similar studies or parallel studies in Spain by Ramon Marti's group suggested that nucleosides could be used as well in cultured cells to treat some of these nucleoside metabolism disorders. So we decided to do the therapy with equivalent doses of nucleosides rather than the monophosphates. And this work was done by Carlos Lopez. And we see very similar results with the nucleosides, a doubling or tripling of the median survival of these knockout mice, depending on the dose of the nucleosides given, with improvements in the mitochondrial DNA levels in tissues early on. But unfortunately, the disease did progress, and of course, the mice did go on to die, but at least there was an effect on onset and survival of the mice. While we were doing the therapies in the mouse, we were, of course, clinically seeing patients as well. And this is one of our early patients who came to us back in 2012, a young boy who was normal in the first year of life, but at age 12 months, his grandmother noted that he had trouble holding up his head. And within 3 months, he lost the ability to sit and just cruise. Sorry. Sorry. So he was admitted to a local hospital and found to be very weak with a very high CK and elevated lactate, and in muscle biopsy showed severe depletion, and whole exome sequencing revealed these compound heterozygous mutations in Tk2. So I'm going to stop the sound here. And this is the child when he came to us at age 19 months. The family drove up from Baltimore. You can see how profoundly weak he is. He's unable to lift his legs at the hips and arms at the shoulders against gravity because of profound weakness. And you can see here he's got very poor head control because his neck muscles are so weak. And this is you can see Dr. Garon examining the patient, and here he can't hold up his head. So we told the family about the monophosphate therapy. We were testing on the mice at that point, and they were interested in potential use of this. And we said we would look into the possibility of trying it on an experimental basis. So the family left and started driving back the next day to Baltimore. And apparently the child didn't look well. So we told father to bring him back to our emergency room, where he was in respiratory distress and admitted to our ICU, and soon thereafter put on mechanical ventilation, and a feeding tube was placed. So we were able to apply to the Food and Drug Administration in the United States and get an emergency IND because this child's condition was so dire. And we immediately initiated this monophosphate therapy at a rather low dose for 1 month, and we went to the second dose. We did that for 3 years. And sorry.
There he's putting in the code.
And you can see him about 5 years after the onset, and he's still on a ventilator, but he's quite alert and moving his arms much better. And he's able to use iPads and computers, and he's learning to write. So we initiated the monophosphate and switched him over after 3 years to the nucleoside therapy, and he improved even further on the nucleosides, which were given at a rather high dose. So after 2 months on the nucleosides, he was able to stand in a stander briefly, or with support of a person, and he began to move his arms better. And he's now 9 years old. He's continuing the therapy for more than 4 years now. He's still on a ventilator and has a feeding tube, but he's able to do more functionally, lift his arms and legs from a bed, and he's able to use his iPad and use a telephone to call his relatives, and he's learning to read and write, and he's able to stand on a stander for an hour and a half. And he's even able now to ride a bicycle, or a tricycle, I guess. So he's clearly shown improvements. We were a little bit conservative in starting him on the therapy on a low dose, and we started him on monophosphates, and now we are treating patients directly with nucleoside therapy. And so more than 40 patients in the world have been treated. This is a report that was published a couple of years ago on the first 16 patients who had received therapy both in the United States and Spain. I should mention the very first patient was treated with monophosphates in Spain. And so we've collaborated closely with the group, the consortium really in Spain, that have treated a number of patients. And you can see here that if you look at the early onset patients against the historical controls to survive, all of the patients who started therapy are still alive. And the 5 patients who are on the early onset are all still alive, of course. And so you can see there's quite a huge difference in survival compared to historical controls. And in patients with motor weakness, we see some improvements in the 6-minute walk test in many of these individuals, particularly those with lower baseline 6-minute walk tests. And we can see those with under 400-meter baseline 6-minute walk test values. They often show improvements in the ability to walk over a period of months. So this is a treatment that has a sustained and prolonged effect and over time. And this child, who was actually from Italy, or in Italy, was unable to walk, is barely able to stand, and after 6 months became able to walk, and now walks more than around 300 meters. So we are very encouraged by this, and because we would like to get approval of this therapy in the United States and in Europe and other countries, the FDA advised us and the company that bought the license for this therapy to roll over our patients from expanded access into a industry-sponsored trial. So I'll talk about that in a moment. This is just to show another child who came to us from South Korea, who's a 16-month-old boy at the time, who had onset at 12 months, and you can see how floppy he is at that time. And you can see that after only a month of treatment, he showed some improvements already. And sorry, he began to move his hands better. Sorry. And here he is after 3 months of therapy, and he's able to use his arms more purposefully, transferring the toy from one hand to the other. He's not able to pull himself to sit, but he's able to, when put into a sitting position, able to sit upright. And you can see he's gained some strength and able to do things more purposefully. And after 6 months of treatment, this is a CHOP INTEND score that improved dramatically as well, but you can see him walking with some support. Here he is with Dr. Valentina Emanuele, who was working with us at that time. And you can see he was able to take a couple of steps. And with further treatment, he's able to walk independently. And here he is nonchalantly walking with his arms behind his back. He's able to move his arms. He's just showing off here a little bit. Okay, so as I mentioned, we started this on an expanded access compassionate use basis, but that was largely put on hold by the FDA. And so we've rolled over those patients into a continuation phase 2 study. And this company, Modus Therapeutics, now bought by a company called Zogenix, has produced GMP grade, that's a pharmaceutical grade product, which is called MT1621. Retrospective analysis of the first 38 patients have been largely completed. And most of the patients who were treated through the expanded access have been rolled over into their phase 2 continuation study. And many of those patients have been on that study for now 2 years. And there will be a new phase 3 treatment naive study called MT1621-104, which will begin hopefully at the end of this year to enroll patients. And they're starting with patients under the age of 16. Later onset patients may, or older patients may be enrolled in part 2 of that phase 3 study, but that's to be determined. So that's the nucleoside therapy story. While we are very pleased with the results of the nucleosides, we've also gone on to try gene therapy. So again, I thank the previous speakers, Carlo Viscomi and Carlos, for introducing AAV to you. We're using an AAV, complementary AAV9 initially, with a chicken beta actin promoter and a CMV enhancer. And we are injecting the mice, TK2 mutant mice with human TK2 inserted into this vector. And we are giving it at birth at 2 doses, initially low dose and high dose, and retroorbitally, just like Carlos. And we see that with a low dose, we see that the mice start to gain some weight, very similar to the nucleoside therapy in the mice. And in fact, the survival at the low dose of the gene therapy is very similar to that which we see with the nucleoside. When you give a higher dose of the AAV9, we see a significant increase from a median survival of 39 days with low dose to a survival of almost 3 months, mean survival with the high dose of AAV9. We saw a good vector transduction in various tissues, particularly brain, liver, and muscle. But this is a little misleading, but if you look carefully, the units are quite different here. In kidney, we see only 1 viral genome per 1,000 nuclei in the kidney. So the transduction of AAV9 when given in the neonatal period is poor in kidney. And I noticed in Carlos's slide, even when he gave it later to the older mice, the transduction in kidney was not great. So we see that not only is there low vector transduction or few copies of the TK2 in kidney, we see that there's this, also less response to the mitochondrial DNA depletion to the AAV vector in kidney. So we think that the reason that these mice progress is largely due to the kidney phenotype. So what we tried to do at this point was then add a second dose of AAV2, because you can't give the same vector twice because of immuno response to the first dose. So we're packaging the vector now in AAV2 as well. and administering the second dose via tail vein, so intravenous injection, day 29. And we do see further improvements with the combination of AAV9 and second dose AAV2. Although the weight growth is similar, we see that the survival improves even further from a median of about 90 days to about 120 days in the combination therapy. And we do see that there's not great expression or transduction of this combination therapy in kidney, but there is, we think, a slight effect. We noticed that between days 20 and 29 in the AAV9 alone treated mice, we see proteinuria in the mice. When we treat them with a second dose of AAV2, the proteinuria largely dissipates. So we think that the AAV2 is reaching probably the glomeruli, perhaps the podocytes, and alleviating part of the kidney phenotype, but not overall in all of the tissue of the kidney. And these, unfortunately, the depletion is not really overcome. So finally, our third approach is a combination of the gene therapies. Oops, sorry. The gene therapies, AAV9, okay, sorry. AAV9 initially at half the high dose, and then a quarter dose of the AAV2. And we initiate the nucleoside therapy in between the two doses as well. So it's a combination of gene and pharmacological therapy. The notion is to replace the mutant protein with the wild type, and then to give the substrate for that TK2, and that combination should be synergistic. And in fact, it is synergistic. We see improved growth with the two therapies together, and we see improved survival. So the survival is almost 200 days, about 180 days with the combination therapy, and one mouse lived up to 16 months. So we're very excited about the use of both the gene therapy in combination with the pharmacological therapy to enhance the lives of these mice, and hopefully maybe translate that into people as well. And this is just to show that, again, the transduction was not great in kidney, but with the combination therapy, we see a slight improvement of the mitochondrial DNA, which may be enabling the kidneys to function a little bit better for a more prolonged time. So with that, I will end, because I think we need a few minutes for questions for everybody. But I do want to just acknowledge the team at Columbia that's worked in the lab, starting with Katerina Garon and Ora Knockin, who developed the mouse and started the monophosphate therapy, and more recently with Carlos Lopez and Maria Sanchez, who worked with the nucleoside therapy. And of course, originally we've collaborated with Guanping Gao, University of Massachusetts at Worcester, who's helped us with the AAV vector production and design. And the clinical team, both at Columbia, and I'll mention the ones in other countries as well. And we're now partnering with this company who's leading really the work, and the early work was funded by MDA and NIH, as well as some private foundations. And these are collaborators around the world who've treated patients, and particularly the group in Spain, led by Ramon Martí, Cristina Dominguez, and Carmen Parades, who've treated many patients in Spain, and as well patient, at least one in Italy, is being treated by Katerina Garon and Maria Alicia Donati, and a groups in Israel and South America, Central America have been collaborating as well. So with that, I'll end, and I'll turn it over to the moderators.